Good afternoon and welcome to the third of 6 free open forums, Telemedicine Now and How, made possible by a grant from the California Healthcare Foundation. Today's theme is Virtually Anything in COVID-19, the many uses of technology for caring. And our very special guest this week is Dr. Dana Lustbader, Chair of the Department of Palliative Care at Optum ProHEALTH in New York. The forums are presented by the CSU Shiley Institute for Palliative Care in partnership with ResolutionCare, pioneering telemedicine in Northern California. I'm Jennifer Ballentine, Executive Director of the Institute, and I'll be your moderator today. The CSU Institute for Palliative Care is a workforce initiative of the California State University system, offering online education in palliative care for frontline clinicians and healthcare organizations. And now I'll introduce our facilitators. Dr. Michael Fratkin is a builder, innovator, and dreamer who approaches life and the practice of medicine with love and respect, incorporating principles of value-based payment, technology-enabled service delivery, and interprofessional team integration. Dr. Fratkin and his team have created ResolutionCare Network to build capacity for high-quality and home-based palliative care in rural Northern California and beyond. Dr. Brian Mistler is Chief Operating Officer at ResolutionCare, a benefit corporation committed to leveraging telehealth technologies to deliver quality care in a racially, economically, and geographically diverse population in rural Northern California. Dr. Mistler is a healthcare leader with a deep understanding of the strategies that drive business impact and individual change. Dr. Dana Lustbader is Chair of the Department of Palliative Care at Optum's ProHEALTH, serving 1.5 million people in the New York metropolitan area. Prior to this, Dr. Lustbader worked as a critical care physician, where she was ICU director, section head of palliative medicine, and program director for the Hospice and Palliative Medicine Fellowship. She is a professor of medicine at Hofstra Northwell School of Medicine and triple board certified in palliative care, internal medicine, and critical care medicine. She is actively working on the front lines, providing critical care to COVID patients in New York City. Without further ado, take it away.
All right. Thank you all so much for joining us. As I go through, I'll be scanning through to see either your smiling faces on real-time synchronous video connection or your incredibly hilarious avatars. There's one with a husky and a harlequin. There's all these cartoon emojis. I thought I saw somebody speaking in the context of meerkats as well. So thank you all for joining me in whatever form, context, environment, ecosystem, habitat you are joining us from. I would like to introduce Dana and myself. Dana is a friend and a professional partner and mentor. Between the two of us, it seems like we both pretty much discovered these things in our pockets as palliative care providers about the same time. See, she's got one too. And both of us started to explore about 5.5 years ago, what this tool might be able to do in the delivery of palliative care. And we've had a lot of fun presenting together and producing technical support documents and such together, and even having a couple of glasses of wine here and there together. Unfortunately, I didn't get to see her at the American Academy of Hospice and Palliative Medicine meeting in San Diego because, like all of us, our lives have been turned upside down over this last month or two. Dana has the unique perspective of being double boarded in both palliative care and in critical care medicine. She also has the unique challenge of living in the greater New York City metropolitan area. So what we've asked her to speak about today is what her experience has been in the very specific context of COVID-19 and how her experience around using these technologies to connect with people at a distance have served her or befuddled her in the context of what's going on in New York City. So Dana, please take it away. Thank you so much.
Thank you, Michael, and thank you for having me. Yeah, so I'm really coming to you right from the epicenter of the COVID-19 pandemic, and have gone back into the critical care units to help provide critical care to very sick COVID-19 patients, as well as bring in some of our my palliative care expertise too. But I just want to start with an example where the two have actually blended, and it was from a patient I took care of on Sunday, and she was 58 years old, otherwise actually perfectly healthy, a bit overweight, a little bit of hypertension, intubated for 2 weeks. And as with her and most of these other patients, they are on a ventilator. Often they are paralyzed with a neuromuscular blocking drug so that they don't move and that they tolerate the ventilator. And they're on very high doses of fentanyl or Versed or other drugs to keep them sedated. And because we are completely overwhelmed with the volume of patients, most of these ICUs are not staffed with critical care physicians or ICU nurses, but rather dermatology attendings or hospitalists that have been promoted to critical care attendings or gastroenterologists. And so the ICUs have a variety of new people that really are not familiar with with standard ICU patients or even medically complex people like these patients. So this woman in particular, I was working over the weekend in this unit. She'd been intubated for 2 weeks, and she was on 60% oxygen, which is still a lot of oxygen, and she was breathing very fast. And because we're using ventilators we're not familiar with, it was a little tiny portable one that's used for transport. So she wasn't synchronizing well with it at all, and she looked terrible. And one approach could have been to sedate her more, snow her. It was Sunday night, leave her for the new team coming in Monday. Another approach is just to kind of really let her wake up and see maybe she'd really do better off the ventilator. And it was unclear which way to go. And you have to imagine in these hospitals, there are no visitors. So all of these patients look the same, and there's no family there at all. So they're all really sick. They all have COVID. Most are upside down on their tummies. We actually call it adult tummy time. So they're upside down because we think it perfuses the anterior lungs better. Flip them over for a few hours a day. So they all kind of have a similar look to them. And it's hard to really remember who's weanable, who can we really work on, who's got family, has the family been called, have they seen their loved one? So with this woman, I just felt like she was really getting ready to come off the ventilator. So I asked the nurses if we could use the COVID iPad and do a family meeting virtually with her son. He was 24, lives with mom, has some special needs. And I just felt like, he needed to see her. He hadn't yet seen her and wanted to. And I just wondered if it might help her wake up more and have more incentive. And so we did a virtual visit. I brought the anesthesia attending in with me because if we extubated her and it failed, he'd be the one who'd have to put all that stuff on, and we put a giant plexiglass box around the patient and reintubate them within this plexiglass box so the aerosol stays within it. So I wanted him to have a sense of, being part of this decision to extubate her. So the son is actually so happy to see his mother on this virtual visit. He starts praying with her in Spanish and says a really beautiful Catholic prayer to her about recovering or something that really motivates her. And she starts to get teary. And you could just see her thumb. She's giving us a thumbs up. She's motioning that she wants the tube out. Her breathing started to really get deeper. So it looked like she could sustain herself. So we took the stuff out, all her lines and tubes out. The anesthesiologist left, but he was available should it not have gone well. And it turns out she looked far better off the ventilator than actually on it. It was really actually increasing her work of breathing. It was sort of like she was trying to breathe through a straw. And what made the difference was seeing her completely wake up as a result of that virtual visit with her son and that family discussion that we had together. And she clearly looked like she had work to do as a mother, and this kid really still needed her. And so it was really powerful. So about an hour or so after she had been breathing on her own, her oxygen saturations went up to 92%, which is very high in COVID-19 patients. She was breathing 20, 25, which we tolerate in this disease, and she looked really good, so good that we were confident she wouldn't likely go back on the ventilator. I then called the anesthesiologist back up to see her because he was not sure which way she'd go either. And he intubates so many people, puts them on ventilators, so many of them, because he's part of the COVID anesthesia squad. in this hospital that's an entirely COVID hospital. 500 COVID patients are in this building. So he's constantly intubating them. And he came back up to see her, and we brought the son back in too virtually. So it was the two of us, the patient and the son, all virtually. And he said to me after we hung up with the son, this was the first time he had ever seen a patient come out the other end, because he said usually his eyes are the last thing anyone ever sees. And it's because so many of the people we intubate don't do well. And here was such an amazing example of how we connected this patient to her son at a time that was so important, really gave her the stamina and fortitude to just kind of really breathe on her own. And it reoriented her, because she really had been out for 2 weeks of who she was as a person and as a mother. And I really feel in this particular case where the weaning parameters in this disease have thrown us all off, because it looks so different from anything we have seen before in terms of its impact on the pulmonary system and on our typical weaning parameters, that she just looked ready. She was giving us the thumbs up, and everything about her looked ready to extubate. And that really would not have happened if we had not brought in the virtual visit with her son.
No, thank you, Dana, taking us inside, and the connection between the total care of people and the technical care of people is critical. We want to offer people the best possible care that match their understanding and their intention and their situation. And to do that, we actually have to communicate with them and their proxies. And these gizmos, these devices are tools for doing that.
Yeah.
Thank you, Dana. Thanks for all your work, and send all of our best to everybody else who you're shoulder to shoulder with in the midst of all that craziness and heartache. Good. Jennifer, do you want to take us into questions? This is designed, frankly, as an open forum, not so much a didactic. We're not here to just unload a bunch of information that may or may not be useful to you. We want you to guide us to the things that you find to be most useful and effective. For all of you that seem to be afraid to turn on your video camera, I'm just going to encourage you to do so. Part of what's new for the Institute of Palliative Care is this real-time, very large group of people to interact with together at once. And in truth, there's so much more by seeing all of your faces, even though you may not speak up or we may not speak directly with each other. To have this synchronous face-to-face connection is part of the whole intention and design of this engagement, so that you get some experience of feeling like maybe you're in a classroom, or maybe you're in a one-on-one with the person who happens to speak. You can set it to be speaker view or gallery view, but I really want this to be a two-way exchange, even though I'm the chatty one in the room. So Jennifer, can you bring some of the questions forward that you've got?
Yeah, so teeing off of what you were just talking about,
Oh, well, isn't that interesting? So I could. So
Jennifer's
Jennifer,
frozen for just a moment. We'll give her a second to unfreeze, and I'll remind people that you can ask questions in two ways. One, by typing them into the chat window, and you can also ask questions by virtually raising your hand. And to do that, one of the easiest ways is to go down to the bottom of your screen and click Manage Participants, and then you'll see at the bottom of the list of folks a little button that you can click that says Raise Hand, and we'll rotate between answering some of the questions that are typed in by the chat window and answering some of the questions from folks who virtually raise their hand.
Good. You know, I'll use this as just a little segue towards a point or a tip that technology is a source of confounding and vexing anxiety for many of us. That we always deal with the blips and the beeps and the freezing and the struggling to get the video and the audio and everything else done. So one of the things that we've talked about in the prior forum, and I'll talk about again today, is that once I've gotten all that stuff settled, I sort of name that. acknowledge it, that everybody's going through whatever they have to get the gizmos functioning effectively. And when that's all settled, I've modeled that I don't get upset about it. And then I start the encounter from that point of view. I'm sure that resonates with Dana. She's nodding her head. Jennifer will almost certainly return to us. I'll tell you, the funny thing about the first forum is that I disappeared for about 15 minutes. And based on an excellent team, Brian and Jennifer and others kept the flow going and the value being delivered. So, Brian.
So, Dana, yeah, a question for you. So you talked about your experience in this wonderful, what telehealth was able to bring in that moment. Can you talk about some of your colleagues and what you're seeing in terms of reactions to telehealth and how folks are making peace with it really rapidly in a way that maybe there was some resistance a few months ago?
Yeah, I think it's a really great point, and I'll speak about it in two different ways. You know, one being on the front lines in the hospital setting, where because there are no visitors there and there are so many patients on all these floors, the only way we can bring family in is virtually. And you know, you have to either go find the COVID iPad, or what I actually just do now is I just put my own phone in a Ziploc bag, because in the hospitals we are all, you know, in our N95s, and we've all got, you know, our goggles and our N95s, and then we've got our suit, our space suit, and our visor, and then it fogs up, and we've got all of our stuff on. And so, you know, that's how patients are seeing us. That's how it's scary for them. And so when we can take our own cell phones and whatever the family has, if it's WhatsApp, Zoom, FaceTime, whatever it is that they have, because the restrictions have been loosened right now, we just run for it. And most of the people in the ICUs that I'm working with have never seen a virtual visit done before, especially by a doctor. And so they are often sort of a little thrown by it. And some of them are, well, I don't know if the family's going to want to see their mom or dad looking this way. But when they see a visit done well, they are completely transformed. And then they'll like come up and bring the COVID iPad to me while I'm there. Oh, this family needs a meeting. Can you talk to this one's family? And there's a whole list of, you know, 10 more families that they want to have a virtual visit with. When I start a meeting with a family, it's a bit different now in the middle of the pandemic. When I call a family, often it's on the telephone just to establish the visit. And I will always start by saying, this is not an emergency. Just like when the school nurse calls you up because your kid has a fever, you know, your first thought is, oh my God, you know, my kid is hemorrhaging at school. That's my first thought. But, you know, some people, you know, you'd worry. So the nurse says that to you. Same is true here. I want to make sure families don't worry that I'm calling to do death notification, because that's really what everybody is hearing right now from a no caller ID or a hospital. So I always start out with, this is not an emergency. This is Dr. Lustbader. Is this a good time to talk? The second thing I always say is, how has the coronavirus impacted you? Because what I'm finding more than half the time is they also have coronavirus, or they're in the hospital, or they've just gone to a Zoom funeral for someone else. So I need to kind of know where they are as it relates to this before I just jump in with telling them how their mom is doing. And then I ask if it's okay for me to update them about their mom. And then I offer them an invitation to switch to a virtual visit if they would like to see her. And when I go in the room, I start sort of gradually, I narrate what we're going to be seeing. Usually I'll start with the ventilator, or I'll kind of orient them to the room. If they're comfortable, I'll ask if they'd like to see their loved one, and we'll slowly move over there. And I'll ask them if that's enough, if they'd like to leave now, or do they want to continue to see their loved one, because most of these patients are not responsive. They're intubated and sedated. And so there's a lot of narrative that goes on with that kind of a visit. But it is completely transformed most of the folks here. And I think a lot of folks are really learning a lot of palliative care skills just by watching a lot of these virtual visits.
Do you find, Dana, that having that sort of framework of entry into the space, those 4 questions, helps people get oriented to the conversation in an efficient way? And my sense being that the kind of work that we have to do in palliative care and in other specialties of communication has to be done about twice as much of it in about half the time. Are you finding that there's efficiencies that way?
Definitely. In fact, there's not a lot of time for each of these calls, and it's also just physically because you're wearing all this stuff in the room, and it's hot and it's hard to stay in the room a long time. It's also not that safe. So I really limit my time. I get everything connected before we even go in the room, and then most of these visits are not more than 15 minutes. And I'll always schedule another follow-up visit the next day or in 2 days, or if something were to change, because people's attention span too isn't an hour or 2 hours. So I really try to ask these questions so I also really get to the point of what I'm calling them about and make sure I've answered all their questions. But you have to really manage your time well.
Great. I'm going to ask another question. This is for both of you, Dana and Michael, and kind of combine a few of the questions that we're getting to the group chat window and a few that I've gotten privately, which is that we spend a lot of time, and rightly so, talking about the virtual interface and that piece of telehealth. But there's also the electronic medical records and some of these other remote things. And so as you're working inside the hospital and bringing folks who are not inside the hospital in via telehealth, maybe to support you with capacity building, or you're outside the hospital and working in the community, what are some of the other dimensions of telehealth technology that need to combine?
Yeah, so certainly bringing other members into the team, into telehealth in general, we've been doing for a long time. I'll just speak now to our outpatient practice and home-based practice. One of the best use cases we have found for palliative care is that if somebody's in the home, let's say it's a new nurse or a new employee that we have, maybe it's a hospice nurse who's joining us in home palliative care, and we're taking care of a heart failure patient that's more upstream and they don't have the skills for that, they might bring in their physician or their pod leader. We might actually do some coaching and mentoring by bringing in another person for that visit so that input could be given. It's a great way to teach. So a lot of times people can do their visit and will tell the patient that the doc is just joining or someone else is joining just to kind of observe, and he or she is part of the team. And as that provider leaves, we'll then debrief with them. And we always debrief in a 3-part way. We start out with what went really well with that visit and try to find something great that provider did, like make a connection, was empathetic, didn't speak too much. We'll then identify 1 or 2 areas to improve, and then we'll end with, again, how well they did, so that we can provide real-time feedback into how that went. Let's say it was a hospice discussion and it got derailed somehow. We might kind of give them ideas on how they could have shored that up. We might step in the midst of it if it's really derailing badly and bring it back on track and let them then continue. So it's a wonderful way in real time for mentorship and coaching, especially with a mobile workforce.
Great. Michael, did you want to add something to that? Let's see if I can unmute you.
No, that's just fine. I just wanted to welcome Jennifer back, your colleague in facilitation.
Thank you very much. I don't know what I missed, so carry on.
Perfect. So I'll read one more question from the chat window, and again remind folks that you can ask questions by the chat window, but you can also raise your digital hand by going to participants and clicking raise hand, and we can call on a few folks and unmute you and give you a chance to ask questions of our panelists as well. So the next question is a really practical one. You spoke to it a little bit with the sandwich bag, but I'll ask again, combine a few questions. How are you managing? Are there enough digital devices? How are you managing to share digital devices between patients? How do you sterilize them? And some of those practicalities.
Yeah, so regarding COVID and hospital-based consults, palliative care consults, if we're in the hospital and doing it in the hospital and doing virtual visits with the patient or the family and the patient, simply taking the device and putting it in a Ziploc bag, and then we don all of our gear, so all this stuff is donned. And when we leave the room and we doff everything, take it off, take the Ziploc bag off with our gloves. So there's a whole process for how we do it so we don't contaminate things. So the gloves and the robe come off, and then we will take the bag off the device, if it's our own device, and then put it in a new bag. And so we just have a lot of Ziploc bags that we can use our own device for. If it's the hospital device, it's also in a big Ziploc bag, and we change that bag frequently, or we just wipe the bag off with the sterilizing solution. So we're not actually giving the device to the patients. They're never touching it. We're the only ones that are holding it, and we're completely dressed like spacemen so that nothing is touching the device. A lot of folks are also doing virtual visits from remote sites to support the inpatient team. Some people can't go to the hospital for their own medical reasons. Some are providing support. New York City Health and Hospital, which is a large safety net health system in New York City, is asking for volunteers to help provide palliative care to 12 large hospitals in New York City. So palliative care providers are actually doing virtual visits with those patients from home, remoting into Epic, and then calling their families and speaking to those kind of families to provide some family meeting and some palliative care support, even to the boots on the ground team. So a lot of innovation is happening very, very quickly in the matter of 2 weeks, honestly, here as we try to meet the need.
Let's go back to the chat window. I'll ask one more. So on the other side, we have somebody asking, we're talking a lot about the positive. Have you heard anything negative or feedback? What kind of negative feedback, concerns, pearls of wisdom do you have around some of the challenges or resistance among families who are using it that you're hearing?
Yeah, so just as an example, this morning in my palliative care clinic, which is just my usual palliative care clinic, some of the challenges certainly are on the technology side. I think I had 12 patients booked and 6 were able to show up and figure out how to download and do all of that stuff through the programs that our provider group wants us to use. We have gotten special permission over the years to use FaceTime, and so for those patients that couldn't figure out the technology, I am able to, because we have gotten special permission to use, even pre-COVID, to use FaceTime or simply call them up and convert it to FaceTime with one of their family members if they don't happen to have an Apple device. So there is frustration sometimes with the technology, but a lot of the patients seem to like this better. They don't have to worry about parking in New York City or waiting in the waiting room. The visits are punctual, and a lot of them liked it better, particularly some of my quadriplegic patients or my patients with advanced Parkinson's disease who really don't have transportation. So it can be a positive. I don't know that there's much of a negative except for the technology and the clunkiness of it. I think when done well, these visits are extremely intimate. You sometimes learn more about them than if they're in the office. You might see that they have a dog or a cat or something else going on that you didn't really know about before. We like to also do an environmental scan. So we might ask the patient to take, or their home health aide to take the phone and survey the area. We might ask if it's okay to see what's in their fridge, look at their medicine cabinet, and we get a lot more information that way when we do that virtual visit and that environmental scan. If we have a social worker in the home and there's a medical issue, that social worker will bring in the physician or nurse to deal with that. So anybody who's in the home, if we need someone else from the team, we can bring that person in. So I think there are a lot of positives in that regard. The other thing too, I just think, again, from a teaching perspective, it's so important as we skill everyone up. I like having other people join the visit, and I let the patient know that I have other members of my team, particularly if I'm in the hospital doing a consult, who are watching and seeing this. It really gives everybody the ability to learn how to have a skilled serious illness conversation. And that's something they wouldn't normally get to do if it was just you and the patient in a room with the door closed.
Yeah. No, I'll add to that. Dr. Mike Rabo was with us last week, and one of the things that he highlighted was that when you do a home visit in this fashion, and I kind of hesitate to call it a virtual home visit because it's an actual home visit, but in a different framework and context. What he said about the environmental scan and looking in the refrigerator and the medicine cabinet and all those things that you can use to sort of extract information, is that it's like when you walk in the room and you can see and feel all this intangible information coming at you. But in this circumstance, you have to ask for consent. It levels the playing field. You're asking to be allowed in or invited into a deeper understanding of the person as a person rather than a patient. And that really changes the game. It actually has efficiency impact. It makes things easier. It holds your attention inside the frame. So whereas Kevin asked the question about when it doesn't work, it's true. There are resistances, but most of those resistances kind of melt away after an experience or two is muddled and fumbled through. There's lots of resistance, and there's lots of resistance actually from healthcare professionals who have a way of thinking about the work that they do and a certain enjoyment for themselves in entering the physical space of the people we care for. So there's a loss there. There's less hugs in addition to less transmission of virus. And those are losses, but on balance, it's extraordinarily well received and satisfying for patients. There's so many gains for them that our small losses seem acceptable.
I'm back. Thank you. Sorry about that. Technology is great, except when it isn't, right? But one of the questions that was submitted ahead of time that I think is relevant to what you were just talking about was how to assist families of 19 patients and what communication tools are needed. And assist is probably a pretty broad question, but one of the things related to that I've wondered about is, given that these patients are alone in the hospital, they don't have family with them, they don't have surrogate decision makers with them, how do you navigate the decision making, and how do you reach out to families and really kind of ascertain who is the spokesperson and how do we get the decisions that we need from them?
Yeah, I think, and it's an especially important question, right now, particularly when we know you don't get into a hospital, at least here in the Northeast, during this pandemic, unless you're really short of breath and hypoxemic, a low oxygen saturation. If you just have COVID-19 and you have a little bit of a fever and you're not eating well or you have some diarrhea, you're going to be sent home. And we basically tell people only come to the hospital if you cannot breathe, because we don't have room for you. We're putting people on ships. We're putting them in the Central Park area. We have a parking lot with a tent where we put patients. And so hospitals have been mandated to increase their size by 50%. So all of the staff that are in these hospitals are from out of state. Many of the nurses are pediatric nurses or neonatal nurses or outpatient nurses. They've never taken care of a sick adult before. And so this is not a good time to be in the hospital unless you can't breathe. So it's very serious. And then out of those that are hospitalized, about a fourth of them will go to an ICU. And out of those that get intubated, certainly we know the mortality rate is very high. It's certainly over 75%. The JAMA paper today that just came out of our health system showed 88.1% mortality for people who go on a mechanical ventilator, but that might be an overly high prediction because it really only looked at people who were discharged or died out of 5,700 people. There's still a lot of people today that are out of those 5,700 that haven't yet died and they're still on a vent. So with advanced care planning now for this disease, there's several things we know about how to give families accurate information about what they can hope for. And if someone's on a ventilator for more than a week or two and they're not making progress and they've developed another organ failure, especially acute kidney injury, we know that they're not going to do well. Also, if they've got a thrombogenic component to their COVID-19 and high D-dimers, they're going to have a very bad outcome, and most of them will have pulmonary emboli or DVTs. So we're starting to see predictors now that help us so that when we have a family meeting virtually, because they're all virtual, we can help families understand what the best case is and what the worst case is based on our decisions. And we're coming up now on 2 and 3 weeks where we're starting to have to make decisions about a trach. And a lot of palliative care docs are getting called in to do telepalliative care with families about this important decision. So really it's either PEG trach nursing home or DNR, and we maybe stop some of the life-sustaining treatments. Or in the middle, which is a time-limited trial of some of this stuff, but basically at 2 or 3 weeks, people are not weaning, they might not. They're most likely not going to. So really hard conversations, and especially because families haven't been able to come in. So we're doing all of this virtually, especially showing families, see what we're doing for your loved one. You can see they have every line tube machine hooked up. Sometimes families didn't imagine that all that stuff was actually happening. They couldn't picture it. So it's really healthy and good for them to see that everything's being done. But these
Dana,
yeah.
Actually, if you wouldn't mind kind of stepping back a little bit, and let's talk about best practices in family meetings, because this is something that most of us have not had the opportunity to do before, even in the best of circumstances when people could fly across the country and show up at the bedside and sit down with them for these acutely ill people. This is a kind of an extraordinary opportunity to weave together, get everybody on the same page. Can you talk about, in the intensive care unit, COVID, non-COVID, what would you consider you gave us 4 principles when you lifted the phone and started speaking to people. Can you talk about some of what you consider to be best practices in setting up family meetings?
Sure. So I think, the first thing I always like to do is when I call a family member, make sure they know this is not an emergency. This is just an update, unless it really is an emergency because they've just coded. But for the most part, it might be about a DNR order, or it might be about the patient is becoming hypotensive. Now something might have changed, or they've gotten intubated, put on a breathing machine. And so the first thing I always say to families on the telephone is, this is not an emergency, or, I have something important to tell you now. But usually I want them to know it's not death notification. So, and then I'll introduce myself. Secondly, I will ask them how the coronavirus has impacted them personally before I jump into talking about the patient. And the reason it's so important to do that, at least here, is that usually other family members have significantly also been impacted. Either they have it. I had a patient, I was speaking to her son last week, and I was enrolling her in a clinical trial, a cerulumab trial, which is an interleukin-6 blocker. So she wanted me to speak to him before we enrolled her in the trial. So I called him up, and I could see that he was wearing a hospital gown, and the paneling of the wall behind him looked familiar. So I asked him how this has impacted him, the coronavirus, and he said, well, actually, I'm just 2 floors below where you're standing. I'm also in your hospital with it. So it was just, important to always ask people how it's impacting them too before you move forward. And then I like to ask what the doctors have told them so far, because again, we have so many new people in the ICUs that aren't familiar with this disease or critical care, or in usual pre-COVID days, you don't know what people have said. Maybe they were overly optimistic. So it's always good to know, where are they starting? What do they know now? And then I ask permission. May I give you an update from what I'm seeing today, right now, with your mom? And then the final thing is I ask if they would like to see their loved one. And then I convert that over to a virtual visit in whatever way is easiest for them. And I gown up, put the phone or the iPad in the Ziploc, which does not, by the way, muffle the sound at all. These rooms are very noisy because of all the ventilators and the negative pressure that's going on. So most of the noise is not from the Ziploc, it's actually from all the other stuff in the room. Some of these ICUs are not separate at all. There's just a curtain between 40 or 50 patients, or not even a curtain. They're just a giant auditorium we converted into a COVID ICU. So it just depends on what room it is. And then I'll bring the family in. I like to start out the visit with the patient, though, not just abruptly showing them somebody who looks scary on a ventilator. We start by kind of looking around the room. I like to trace the ventilator. I explain this is a breathing machine. It's a ventilator. Here's the tubing. We're now going to see the back of your mom's head, and then we sort of move around to look at the front. And I ask them if this is okay for them. Are they okay with this? Do they want to still say something to their mother? Let me know at any point when you want to leave the room. Not everybody wants to stay a long time in here. It's okay if you want to leave now. And what I have found is most families, they're not in a rush to leave, even though the patient might look scary, look different, unresponsive. They want to see their loved one. They want to say some things. And I hold the device close to the patient, and I tell the family members, your mom can hear you. We think people can hear when we're in the room. We assume she hears. That's why we speak respectfully when we're around her. So I'm going to put the phone right next to her ear so you can say whatever you want to your mom. And then I'll sort of pan back out. If the nurse or respiratory therapy is there or someone else is there, I'll show the family, here are other team members that are helping us care for your mom, so that they can see that there's a full team of people thinking about their loved one. I'll then ask if they're ready to leave the room, if they have anything final they want to say to their loved one, and then we'll exit the room at that point.
So just a follow-up to that, is this on the telephone, or is it video, or both?
It's a video, so it would be either I would be using Zoom or FaceTime. I'd be right on my own device, or I'd be using the ICU's iPad. We might use WhatsApp. We will connect with the family in whatever way is easiest for them virtually, but cameras are on, just like we're doing here. All the cameras are on, so I can see them. Sometimes it's telemedicine squared, we call it, where we're doing a visit like this, but they've called somebody else on FaceTime, and so they've got somebody on FaceTime. I'm doing FaceTime with them, and we're all doing it sort of squared. So they might have called somebody who lives in Chicago to bring them into the conversation, and I'm with them, and they come in too. And so we'll have a bunch of devices. And we have just found whatever works. We will just make sure that we can do that. We might bring in a second device. And then we've got Palliative Care cubed. And so, however many devices it takes to connect people.
No, this is the principle, isn't it? It's you've got to explore what's in your toolbox. You've got to use them to see what is necessary to pull this off. And that in the environment that we've been challenged by and offered in COVID-19, we have freedom for platform use. So there was some in the chat mention of HIPAA and security issues. We've been given a reasonably open framework for the use of any platform that connects by video. That's useful. That includes things like FaceTime, Skype, Facebook Messenger, and a number of other proprietary platforms, including Zoom, which is what we use a lot of. The principles of this family meeting really start to look like the best practices for any family meeting, just done in a unique and new way. The idea of getting everybody coordinated and arrived at the same spot, for me, that's oftentimes leaning on the members of my team as a care coordinators to get the family members in the right place at the right time with the right link and the right gizmo, and getting their audio and their video tested, and getting everybody in the same time is a big piece of coordination that I'm blessed by having a fantastic team to accomplish. Once I walk into the room, I check in with everybody to see, are they still fumbling and bumbling? Are they still holding their device? And is it jerking around and jiggling? And I'll do some coaching to get them to drop in to the environment, to free their hands up, prop up their device so that they can let the technology itself kind of disappear. And then we set the space. When I walk into a hospital room, I always sit down. I always take a deep breath. I always model a groundedness with how I walk into the space. And that's exactly what I do within this new framework as well. And then, as I mentioned before, I acknowledge that it took whatever it took to get there.
Yeah.
And I say, now we're beginning this encounter. Now we're beginning this conversation about this person that you love. And that little bit of managing the setting and managing the stage for the encounter is really important. It can help you to arrive at that start point as well.
So as a follow-up to that, We had a question in the chat box. Where in the process do you recommend to bring in your palliative care social workers for emotional process and anticipatory grief and support of other kinds?
Yeah,
Dana, you go ahead in the hospital setting, and then I'll talk a little bit about how the home setting works.
Yeah, I'll tell you the truth. Right now, because of the exposure risk, we don't have a lot of social workers or other people in all of these buildings. We're really short staffed on that. A lot of folks are actually working remotely, so they aren't physically there. And a lot of people have also just gotten sick. So we're really short staffed on that. I will say though, in our home palliative care program, even pre-COVID, our social workers were doing a lot of virtual visits. And that was one way that allowed us to leverage their expertise. And just like telepsych has worked so well, patients really love it. And our social workers enjoy seeing patients' faces. It gives you a lot more information. So they do a lot of their visits pre-COVID. They were doing a lot of them virtually anyway. And now they're doing all of them virtually. In the hospital, I truthfully, I do wish we had more social workers who were able to provide support. It's just right now so hard to go in. And even in these giant ICUs, really all you'll find in there are going to be the ICU nurses, docs, and respiratory. It's just such a high aerosolized environment. It's really not safe to bring in other people who don't have to be there.
Yeah, no, that's right. And I think because our program is fundamentally the core offering as home-based palliative care with an interdisciplinary team. When we transitioned to 100% telemedicine, it was fairly seamless because our staff and the people that we're seeing have become accustomed to at least a proportion of their care to be done this way. When we went to 100%, probably the most resistance we had was really from staff members who, again, have this personal sense of wanting to be in the space with people. So they had the biggest adjustment, but once they made that adjustment, about 24, 48 hours later, they're doing exactly everything that they've ever done before using this technology. Yeah. So we involve at time of enrollment our nursing, social work, chaplaincy, and then provider, all in a sort of a rolling assessment process going over 2 to 4 weeks to completion. And this is the channel by which the people we're caring for at home experience care. And then they're riding the telephone all the time and arranging and coordinating with other agencies and resources to solve problems after they've identified them. But this is the way that our clients or the people under our care experience their team.
There's one question in here. It's a really good one too. Do we ever see a time when we'll hug or touch our patients again? And I do worry about that. And certainly it'll be a long time because I'm more worried about giving them something from me. And I think there are a lot of ways to convey love and intimacy virtually. And I have found, incredibly intimate connections to patients this way by looking directly at the camera, first of all, and not down. So being mindful where my eyes are looking and glancing down at their face, but really back up at the camera so that from their perspective, they feel that I am completely looking at them and I'm leaning in. I know, Michael, you've probably even taught me that trick, but it really is so important that people feel like you're just looking right at them directly. And I've had patients share that this is just so intense. They just could feel connected and grateful for the intimacy. So I know we're a touchy-feely kind of specialty, but I think that a lot of our love and concern can be conveyed if we do these kinds of visits well. And I don't know that you can do it on a telephone certainly as well, but by turning on the camera and really looking at someone and seeing them and them seeing us, they feel the love from us. I don't know that it has to be by touch. I think there's a lot of nonverbal cues that we're giving off as we lean into the camera and look directly at a patient.
Yeah, I agree 100%, 1,000%. And then I'll add to it that by creating a frame around this relationship, there adds a level of intentionality that, how do I say this? It's kind of nuanced, but there's a boundary, an unassailable, unbreakable boundary between myself and all of you, which means that I am called, and I have a reflection of myself. I get to see myself on video, right? I am being called to be responsible for what I bring into this environment, and to recognize that the other person that I'm interacting with is some actual other person, very consciously, very intentionally. And when I walk into a house, my role and the power dynamic is such that that's confusing. The projections that come, the transference that's a part of being a healer or being a patient, those two identities complicate the space, and below our level of consciousness can interfere with our ability to really recognize the I and thou. If you are familiar with Martin Buber, that's the place where truly understanding and truly connecting empathically without collapsing into that person's stuff, to really own your own role as the healthcare provider, as a person bringing service to somebody, without becoming too intertwined in their stuff, provides actually greater intimacy than real life, says me.
There is an important question here in the chat that I want to throw out to you, and that has to do with families and people with intellectual disabilities. And by that, I mean, I assume is meant, dementia, other kinds of developmental disabilities. So you all have exquisite communication skills, says the asker, but what can you recommend for families as to what and how they can ask from the communicating healthcare provider? How do you sort of navigate that challenge?
Go ahead, Dana.
Yeah, so certainly bringing in other family, if it's a patient who has dementia, it's always important to talk to their other family caregivers or paid caregivers or whoever they have designated to take care of them. I did a visit this morning with somebody with very severe dementia, and her niece was there facilitating the conversation. So we started the conversation virtually with the niece, because she had a whole lot of concerns about Seroquel and Ativan and different kinds of drugs, because this patient was having aggressive behavior at nighttime. So getting that kind of history was helpful. We then took the visit into the bedroom where the patient was on the bed, and I already had this background in my mind, so I sort of knew what we wanted to focus on, and then saw the patient. And then we came back and sort of finished up with the niece. And so I think there can be some flexibility as to who we're visiting with, and understanding who's actually providing the care. So it might be talking with the daughter, the paid caregiver, and then going to see the patient and introducing myself to the patient. And I commented on her beautiful pink nightgown, and so I got a real sense of who she was and what her limitations were, and then going back to talk with the family. So really just being flexible and talking with other people caring for the patient. But I think it's true with everybody. Honestly, when I talk, I really try to be very mindful of not using medical jargon and just speaking normally to people, so that when I use the word ventilator, for example, I'll say it's a ventilator. Some people call it a life support machine or respirator, but it basically blows air into the lungs and helps people breathe. I will explain every single thing, even if it's something that's pretty standard, because I just want to make sure they understand that stuff. So I think it's really important as we're talking about these things, particularly in the time of COVID, when there's a lot of machines and treatments happening to people. I explain, I don't assume people know even what dialysis is. I explain it's a kind of a washing machine for the kidneys, and it cleans out the blood. And there are a couple of ways we can do dialysis. And so I'll explain every single word in very basic terms, just automatically to everyone, whether they're an attorney or they have special needs or they have dementia. So I really try to make it very clear in my language for everyone.
Yeah, no, I think that's exactly right. When we're dealing with people who have cognitive impairment, dementia, or otherwise communication difficulties, it's always important to remember that at least from a palliative care perspective, the person caring for that person is central to your offering as well. And so those are opportunities then to really provide support, really inquire how the caregiver is doing, and to let them know how important the work that they're doing is, and that they're doing a great job. That goes a long way as well. There's one trick that came up in a prior discussion that I just thought I'd share, is that in fact, there are advantages to using gizmos like these or headphones for people who are hearing impaired, so that they have a high volume experience, but the rest of the world around them is not burdened by having to listen to screaming. So by having headphones available or earbuds available that an individual can manage their own necessary volume, we actually get a little bit more ground covered with hearing impaired folks. But these kinds of challenges, cognitively impaired people, people with mental health issues that are quite profound, people with visual or hearing impairment, these are all great challenges to regular old face-to-face in the exam room medicine. We have some tricks that give us advantages, but there's no panacea. Those are just hard, difficult situations. We just have to be creative and thoughtful about addressing.
There's a very good question here about PTSD, and you know, in the height of the pandemic for healthcare workers, and I am also extremely worried about that. I was walking out of the hospital 2 weeks ago, and one of the nurses, somebody had just died. It was 8:30. We were walking 8 p.m. and we were walking out together, and he shared with me, he was crying, and he shared with me that he's a floater from Texas coming up to New York to help with this pandemic, and it was only the third time he had ever seen anyone die in his entire career. And so I think there are going to be a lot of these kinds of things, and there's just no time to process it in the height of it right now, but you know, it's going to take a toll on people, and there are a few things that I think are really helpful. One of them is there are free apps for healthcare workers right now. One of them is a meditation app called Headspace, and they're giving it out for free to people. The second thing I think that's been very helpful for me and a few of my colleagues is we do wine night every Tuesday. A few physicians and I get together every Tuesday night for an hour or two and have wine, and we turn our cameras on. And so I think now more than ever, turning cameras on and seeing each other and supporting each other is key. And then the third thing is there are some WhatsApp or Slack groups that are supporting each other through this in the New York, especially metro area, where we're getting hit hard. And so I think these are all strategies to provide support to one another.
Well, thank you.
Go ahead. Good.
We are actually at the top of the hour. It's gone by. I can't tell you, Dr. Lustbader, what it means to us to have you with us, and know that we're with you in your challenges at the moment. We wish all the best for you and your team. Dr. Fratkin and Dr. Mistler, again, thank you so much, and see you next week.
Thank you.
Thank you.